good evening. Thank you for coming. It's nice to see so many people here. So I'm going to try to address management of chronic joint pain, and to which some of you may be expertise in as experience with it. So what is pain? We'll go with the clinical definition. It's an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. So that's from the International Association for the Study of Pain. It's been with us for years. But really, I think probably for many people in this room, this is what pain is. Pain is stress. It could be a result of an injury. It hurts. It's constant, could be intermittent. For some, it makes it hard to get out of bed, to enjoy life, to be able to work. It can have impacts on one's mood, one's sleep, and ultimately it can lead to depression. So defining acute pain is really much more straightforward. It's typically predictable. It's a response to a trauma, to an injury, to a surgery. We can really make sense that A caused B and have a path to treat that pain. And we define it within months of pain that's just occurring for a 3-month period. Chronic pain is pain that lasts longer than that 3 months, or it's past the time of normal healing, of what we might expect. And unfortunately, it affects 1 in 5 Canadians. So how do we treat such pain? We really focus on it being a multidisciplinary approach to pain control and a multimodal, and so I'll explain that. We try in pain management to really establish goals, really what's your comfort goals. So how much pain can one manage in order to do your activities of daily life, and what pain control do you require in order to function? So those should always be on practitioners' minds when we're developing a plan for pain management with patients. The point of multimodal is that we're using more than just one treatment. So our best approach is if we're using a combination of non-opioid medications, if necessary, and non-medication treatments. So the idea behind it is that we're not just treating pain, we're improving one's function. We use different types of pain medications so that we're affecting the nerves and signals, and we're not just relying on one type of medication on one receptor. Using just what we used to call like monotherapy, where if you're prescribed one type of pain medication, is really quite old school. We really want to have at least 2 medications going, working at, as I said, like different types of receptors to manage pain. Non-medication therapies, a lot of what Wesley spoke about with physical interventions. So you can have active physical interventions, you can have passive physical interventions, such as spinal manipulation with a chiropractor, massage therapy, and psychological therapies are also very important. The mind plays a big role in how we perceive our pain, how we catastrophize pain. So self-management programs, mindfulness as a stress reduction technique, and then interventional treatments, which Dr. McMahon touched on with injections. But you find either surgeons will use those, chronic pain clinics will use those, where we can put injections into the area or the source of the pain. Non-opioid, so many people are familiar with the term narcotic. I prefer to use the word opioid, but non-opioid pharmacotherapy. So these are the common medications that we would prefer to be using for pain control. So you'll notice that none of this has opioids on it. Tylenol, anti-inflammatories, anticonvulsants are drugs that we used to use a lot for neuropathic pain, but now find that we can use it in chronic pain and acute, even post-surgical pain. Antidepressants, and then topical ointments and medical cannabis. So what if you say, I've tried everything. I've tried all that. That all sounds great. I've tried the physical therapy. I've tried to go for a massage. I am still in agony. That is where we bring in the different medications, such as the medical cannabis, and then further I'll talk about opioids. So this clearly will be a big part of our world in 7 days, but has been a part of chronic pain management for a long time, just having much more prescribed access. The 2 real components for pain control are the CBD and the THC. As far as just a quick breakdown on them, the CBD interacts with pain receptors in the brain to exert pain relieving and anti-inflammatory effects. So when we're talking about medical cannabis, it's the CBD that's the higher concentration, and then THC, which that's the component that's responsible for the body and brain's responses getting more of the high or the intoxication. So ideally, if you're using it for pain control, your prescriber is giving you higher CBD and lower THC. And then we have opioids. And I have to say, and you're probably not as surprised, that our pendulum is swinging to the other side of where we're using our opioids for pain control. I think that there's still definitely a place for them, but where that lies is probably where you need to be using them in lower doses, and certainly not as a first-line treatment. It really is, if we've tried everything in those lists that I had, then we're introducing opioids. And I think that if opioids are prescribed, there is a significant conversation about the risks and benefits, and where do they play a role in your life, and are you willing to accept some of the risks? And certainly that we are prescribing them for shorter durations, and our follow-up is much more immediate with patients. We're not giving a prescription for months, we're giving a prescription for a month and following up with our patients. It may be hard to think in terms of chronic pain, something like arthritis that goes on and it's months of inflammation, that we're just using short term, but that really is the idea and the intention with opioids. How do we manage our pain control for the surgical population? So we do, Markham Stouffville, and probably for most centers, are doing analgesics prior to you even going into an OR. So this is common treatments that I'll list here for joints. So patients are getting an anti-inflammatory Tylenol even before they're going in for their surgery. And the whole concept behind that is that we don't overstimulate the nerves. We know in pain control that if we can keep nerves calm, that will even prevent nerves becoming overstimulated, misinterpreting pain, and becoming a chronic pain problem. We give spinals for our lower limb surgeries. So instead of giving a general anesthetic, which has more difficulties recovering from, sometimes that's reasonable for some surgeries, but we will give a spinal, which is putting an anesthetic into the back, most familiar for a female during labor and having an epidural, but we can do that where we numb the lower extremities. We give nerve blocks into the area. So this is, I should mention that the spinals are done by anesthetist, but nerve blocks are where a anesthetist will inject a local anesthetic into the nerve that's going to infiltrate the area of the surgery. And those will last, providing pain control up to about, ideally 12, 16, even 24 hours. For some patients, for many patients, we're giving steroids and intra-op, and we can use ketamine for a subpopulation of patients. We know that that's effective for joint pain control, and it's a non-opioid treatment. And as I mentioned, very much so in our acute pain management of patients is that we have in mind that everything we need to do to really treat acute pain so that it doesn't become a chronic pain problem for patients. So we're aggressive off the start, even like with giving a nerve block before surgery. So those nerves just stay calm. They don't get stimulated because they're firing, and you have a much better outcome. These are a couple of resources. They tie in with opioid prescribing, so you're aware that they exist. They're good patient-family resources that you can access off the internet. For the opioid prescribing is the resource that I showed you earlier that physicians and nurse practitioners would use, but as well patient resource.